Morning everyone, a very warm welcome to our instruction course, Retinal Vein Occlusion A to Z. Let me introduce our team. Our chief instructor for today is Dr. Sarita Berry ma'am. Ma'am is Director, Lady Harding Medical College, and she is heading the Retina Services. Ma'am has a vast experience in this topic, and I hope you will gain some insight into it today. I am Dr. Neha Chawla Gulyani. I am an assistant professor at the Department of Ophthalmology, Lady Harding Medical College. We have with us Dr. Rahul Bhatia. He is a consultant at Sharpsight Eye Center. We have Dr. Bharti Arya, who is a consultant, vitreoretina consultant at Medanta. And we have Dr. Aditya, who is a senior resident at the Department of Ophthalmology, Lady Harding Medical College. So today we'll be discussing from the overview etiopathogenesis to a case-based discussion of the evaluation of RVO, the clinical trials that have been done so far in relation to RVOs, then the management strategies, the anti-VEGF, steroids, and last but not the least, the role of lasers in RVO. So without any further ado, let us start with the overview. So retinal venous occlusion is the second most common retinal vascular disorder, second only to diabetic retinopathy, with a prevalence of 4 in 1,000 according to a meta-analysis done on 50,000 patients from 11 studies. They also found that branched retinal vein occlusion was much more common than central retinal vein occlusion. And in a study conducted in the rural population of central India, we had similar results, with the incidence of RVO being 0.8% and BRVO being 7 times more common than CRVO. There is no gender predilection, affects males and females equally. But what is the point to be noted is that there is a risk factor of age. Most of the patients are above 65 years of age. How do we classify RVO? With the pioneering and extensive work of Dr. Sohan Singh Haire, he described 3 primary types of retinal vein occlusion, and each primary type had 2 subtypes, making it a total of 6 forms of RVO. First is the central retinal vein occlusion, where the entire venous system of the eye is affected, and the occlusion is at the level of lamina cribrosa or just posterior to it. Then we have the hemicentral retinal vein occlusion, where one hemisphere of the fundus is involved. It is due to the occlusion of one of the 2 trunks of the central retinal vein in the optic nerve. Then we have the branched retinal vein occlusion, where it is divided into major and macular depending on the site of the occlusion at the AV crossing. It could be major or macular. So in this figure, you can see the blue arrow point towards the site of insult of a major BRVO. The major vessel is affected, whereas the green arrow points towards a minor tributary draining the macula. So a macular BRVO. And CRVO and hemicentral retinal vein occlusion are further divided into an ischemic and non-ischemic variety. There is another entity where we have seen that RVOs might be associated with retinal artery occlusion as well. So there might be CRVO with CRAO, or CRVO with a branched retinal vein occlusion, or a cilio-retinal artery occlusion. So what exactly causes the retinal vein occlusion? Well, the exact pathogenesis still remains unclear, but what we do know is that there is a multifactorial etiology. The condition is due to a combination of 3 systemic changes known as the Virchow's triad, which includes hemodynamic changes, the venous stasis, degenerative changes of the vessel wall, and blood hypercoagulability, all these 3 acting to form a thrombus. So the site of CRVO, the insult is typically at or just posterior to the lamina cribrosa. Why so? Because in this site, the vein and the artery, they share a common adventitial sheath. For this reason, mechanical narrowing of the lumen of the thin wall vein due to the arteriosclerotic rigid hyperplastic thick arterial wall will cause a venous occlusion. Whereas in BRVO, the site of insult or the site of occlusion is the AV crossing, where the artery crosses over the vein. So again, when the artery crosses over the vein and the artery is arteriosclerotic, it will cause a venous stasis, which is turbulent blood flow, producing injury to the endothelium and finally leading to the occlusion of the vein. Another thing to be understood is the pathogenesis of macular edema, because if most of the patients with BRVO, they come with diminished vision due to macular edema. So how does that happen? So when the vessel is occluded, when there is a blockage of the vessel, there is a back pressure leading on to hypoxia, which causes the release of vasopermeability factors or the VEGFs, which will cause the breakdown of the blood-retinal barrier, and this leads to fluid flux from vessels to tissues. So what are the risk factors leading on to a retinal vein occlusion? They can be systemic risk factors or ocular risk factors, glaucoma being the most common ocular risk factors. Amongst the systemic risk factors, first and the foremost is hypertension, which is seen in 2/3 of these patients. Diabetes mellitus is seen in around 15% of these patients, whereas hyperlipidemia can be seen in 1/3 of the patients with RVOs. And obviously there is the atherosclerotic associated diseases like ischemic heart disease and cigarette smoking. There are a set of risk factors which are more prone to cause an RVO in the younger age group, where arteriosclerosis might not be the main cause of causing the venous occlusion. So these are the occlusive periphlebitis due to systemic vasculitis like systemic lupus erythematosus, sarcoidosis, syphilis, or any hyperviscosity due to hematological neoplasia like polycythemia vera, multiple myeloma, leukemia, or hypercoagulable states like antiphospholipid syndrome, protein S deficiency, or the intake of drugs like oral contraceptives. As I had already told you, CRVO can be subdivided into an ischemic and a non-ischemic variant. Why is this important? Because the prognosis and management of these two entities is vastly different. So how do we differentiate between these two? We have certain morphological tests as well as functional tests. So first in the functional test is the visual acuity. It is seen that cases with ischemic CRVO at presentation they have poor vision, a vision of 20 by 100 or less, whereas non-ischemic CRVO has better visual acuity at presentation. RAPD or relative afferent pupillary defect is present in ischemic variant. So are dense central scotomas and peripheral visual field constriction on perimetry. And on ERG, the B wave amplitude is less than equal to 60% of the normal in cases of ischemic variant. Now morphologically on ophthalmoscopy, as you can see in these two pictures, the one on the left is the ischemic variant and the one on the right is the non-ischemic variant. So between the two, you can see more marked venous dilatation and more extensive hemorrhages and cotton wool spots in the ischemic variety. And on fundus fluorescent angiography, what you see is more than 10 disc areas of retinal capillary non-perfusion, as is seen in this picture, where the picture on the left shows extensive areas of capillary dropout, whereas on the right you can see not that many areas of CNP. And with the advent of ultra-wide field angiography, there is something called as an ischemic index, which is the ratio of capillary non-perfusion to the total visible area. If it is more than 45%, or if the total area of non-perfusion is more than 75 disc areas, this predisposes to neovascularization. Another potentially blinding complication of ischemic CRVO is the anterior segment neovascularization, which may lead to neovascular glaucoma, which is a blinding condition. So we also need to know the natural course of the retinal vein occlusion. Why is it important? We need to know the natural course of a disease to predict the treatment outcome. So in CRVO, if it is a non-ischemic type of CRVO, most of the cases have a spontaneous resolution, whereas in ischemic CRVO, there might be anterior or posterior segment neovascularization. And the potential of conversion of non-ischemic to ischemic is 12 to 30% over a period of 3 years. Whereas in a BRVO, most of the cases have a spontaneous resolution, but in BRVOs with extensive CNP areas, it is said that 40% of them would develop NVEs and 40% of those will have a vitreous hemorrhage. So now with this overview in mind, I would request Dr. Sarita Berry ma'am to present her case-based discussion on the evaluation of CRVO.
There? Beautiful overview of etiopathogenesis of retinal vein occlusions, which is extremely important in your retina clinic. After diabetes, we see so much of retinal vein occlusions, which have actually increased after the COVID for some reasons. So today I'll be telling a few cases which we generally see. Sorry. So I will be going from the most common cases which we see in our clinic to which are little rare and are curious. So we identify the risk factors and interesting adage, every eye tells a systemic story, and anything which is happening in the eye you should correlate with the systemic problems. So we have already said the blockage of the, how do you get a pointer? There's one. So since we know that here once there's a blockage here and the blood cannot be drained back here, so there's a back pressure, edema, ischemia and vision loss, which Dr. Neha has already explained. And the systemic clues which we need to, which are really important for retinal vein occlusions is hypertension, diabetes and clotting disorders. So going on to the cases, the first case had a decreased vision for 3 weeks. So interesting to note that usually patient come after some time. They keep thinking that this curtain type of a vision will clear off, then it doesn't clear and he comes, so the worst eye has 20/40 vision. And on fundus examination, you see this subprotemporal hemorrhages and AV crossing changes because of hypertension. So when you see this fundus, you see this hemorrhages and AV crossing nicking changes are already there, giving you a clue that it is a hypertensive retinopathy as well. So on workup, the blocked fluorescence because of hemorrhages and also because of CNP areas, BP is 150/90. So systemic hypertension and atherosclerosis is the diagnosis. So the second case, so in this we have a workup and systemic conditions. The second case, 60-year-old, again for 3 weeks, hypertensive with occasional smoker, so history is important. The worst eye has 20/40 images. This is the same case, I'm sorry. Case 2. So this is a blurry left eye in a 55-year-old lady for 1 month and has hypertension and a borderline diabetes. On the worst eye, vision is 20/60, dilated veins in all the 4 quadrants, dot blot hemorrhages on all the 4 quadrants and mild disc edema. So on workup, this you can see the central macular edema with some subretinal fluid, delayed venous filling on blocked fluorescence in FFA, glycosylated hemoglobin being 6.4, pre-diabetes, which she was not aware of earlier. So systemic screening for diabetes, hypertension, again important. So another case of sudden vision loss for 2 weeks. Patient had hypertension, glaucoma and past history of cerebral vascular attacks. The vision is not so, is very bad in the affected eye, and on you can see the blood and thunder hemorrhages with cotton wool spots. So this is, and there's an RAPD also. So this is a case of ischemic retinal vein occlusion. The third case with severe, so case 4 is a 32-year-old lady with migraines and was on oral contraceptives. The worst eye vision is not so bad, is 20/50 with scattered hemorrhages, and even the macular edema is also not much. So it's a non-ischemic with some hypercoagulable state, protein S deficiency, especially contraceptives, they lead to hypercoagulable states. In a young patient needs full history and workup. So in a young patient, hypercoagulable states need to be worked up. Even homocysteine, serum homocysteine levels, which in India we have found is a very important cause of hypercoagulable state in a young patient because of inflammatory causes, mechanical factors like optic dysfunction, lifestyle, smoking, dehydration, especially in summers. We get cases where there could be dehydration and causing RVOs, and systemic links like hypertension, hyperlipidemia, and diabetes. So in cases of vasculitis, so we can see oral ulcers, Behçet's is one of the very important causes. Vision is not that poor, and ancillary workup for all these vasculitis, including Behçet's, tuberculosis, is important in India. So another case where there is an immune trap, you can see a sudden right eye vision drop with fatigue and prior miscarriages, and the vision is 20/100, diffuse hemorrhages, blood and thunder. Immune trap causing severe macular edema. This is a lupus, anticoagulant positive, so anticardiolipin antibodies high. So these are another type of BRVOs. Then sticky blood in a 40-year-old marathon, left eye blur, vision not bad. So this had a hemoglobin of 19 with hematocrit of 57%. So hyperviscosity syndromes is also not so uncommon, though rare. So systemic links like Behçet's or Eales disease, antibodies, polycythemia can have in young patients and hypocoagulability states, especially hyperhomocystinuria. So a brief workout for all patients, usually above 65, as Dr. Neha had said. So usually the history of systemic diseases like hypertension, diabetes, hyperlipidemia should be taken and also checked. Also a history of eye disease like glaucoma. Then imaging is important, especially OCT, which actually leads us to not only how to diagnose and what treatment to give, and the prognosis and follow-up. Fundus photo is taken to also tell the patient how much is the problem. FFA, though not so common nowadays, but it is important, like in the end you will see why photocoagulation, an indication of photocoagulation is by FFA at a later stage when you see so much of ischemic areas. So systemic screening for BP, sugar, lipids has to be done, is important, and for eye for glaucoma. Clotting profile in young patients, especially serum homocysteine levels. This I've already said, the hypertension, diabetes, dyslipidemia again and again, then glaucoma and cardiovascular disease, hypercoagulability states, and so in fact in examination I will like to say, like, vision, as Dr. Neha had said, is very important to distinguish between ischemic and non-ischemic. So poorer the vision, more the chances that it will be ischemic. Intraocular pressure and pupil. So this you must check for all patients on all the follow-ups, because that will lead you to help patient the best. Sometimes an ischemic, non-ischemic becomes ischemic. So a long follow-up, not that if the patient giving anti-VEGF has become good vision, you leave the patient have to be followed up. Earlier it was a 90 days glaucoma, now it has become 180 days because you are giving anti-VEGFs and the new vascularization comes up late. So please follow up these patients for a 6 months time and see if they're becoming ischemic, and laser has to be done, which we'll be discussing later. Thank you.
To invite Dr. Rahul Bhatia, who is a vitreoretina consultant at Sharp Sight Eye Center, Delhi.
Good morning all. I would like to thank AIOS and APO for this opportunity. I will be discussing about the latest clinical trials in RVOs. We'll explore the evolution of treatment from laser therapy to latest anti-VEGFs. Let's begin. I have no financial interest. The introduction we have already seen. The treatment guidelines gives us a broad overview of the evolution in treatment. We started from laser photocoagulation to now anti-VEGFs to now newer agents for BRVO. The BVOS study was a landmark trial that assessed the effectiveness of laser photocoagulation in BRVO. The study aimed to determine whether scattered laser prevented neovascularization and if grid laser improved macular edema. This was a well-designed randomized controlled trial with a 3-year follow-up. The patients were divided into observation and laser photocoagulation groups. Importantly, inclusion criteria required vision worse than 20/40 and edema persisting more than 3 months. The criteria that might feel outdated today. The findings were clear. About 1/3 of the patients showed spontaneous improvement early on, but laser treatment significantly improved visual outcomes compared to observation. The gain in visual acuity was over 1 line more than the laser group by the end of 3 years. Despite being foundational, the BVOS study had several limitations. The patient selection was narrow, the treatment was delayed, and modern diagnostic tools such as OCT was not available at that time. Today, its methodology seems outdated, but its historical significance remained. Now we come to trials for steroids. The SCORE BRVO trial investigated whether intravitreal triamcinolone was superior to laser treatment. The patient was randomized into 3 groups, 1 mg, 4 mg IVT, and standard laser treatment. The study found that no significant visual benefit of IVT over laser. However, steroid had a higher rate of cataracts and IOP elevation, particularly at 4 mg higher dose. Thus, laser therapy remained the standard treatment for the time being. The Geneva trial assessed dexamethasone intravitreal implant for macular edema in BRVO and CRVO. More BRVO patients gained more than 15 letters with dex rather than sham group. However, the adverse effect was similar to the triamcinolone group. Now we come to trials for ranibizumab. Bravo was a pivotal trial assessing ranibizumab in BRVO. It included 397 patients randomized into 0.3, 0.5 and sham injection groups. The primary endpoint was more than 15 letter gain in BCVA. Ranibizumab significantly improved vision compared to sham. The 0.5 mg dose showed slightly better outcomes than 0.3 mg. Additionally, fewer patients required laser treatment in ranibizumab group. These are some of the extensions of Bravo study with long-term follow periods. These long-term studies established that BRVO had a chronic component and required multiple injections and continued monitoring. Now we come to aflibercept. The Vibrant study investigated aflibercept for BRVO and found that it improved vision outcomes with extended durability compared to laser photocoagulation. The Copernicus and Galileo trial examined aflibercept for CRVO. The patient gained 17 to 18 letters at 6 months, confirming aflibercept as a potent treatment alternative. Now we come to newer drugs which are available. Brolucizumab is a next generation anti-VEGF agent, offers longer durability with dose intervals up to 12 weeks. However, few patients have shown higher risk of inflammation. Kite trial was a multicentral trial comparing brolucizumab with aflibercept. It showed non-inferior visual gains compared to aflibercept, with more patients achieving extended dosing. Macular thickness reduction was greater with brolucizumab. However, intraocular inflammation were reported. And these are some of the other trials of brolucizumab in RVOs. They established similar visual gains and fewer injections as compared to other anti-VEGF agents. Now we come to faricimab. It is a bispecific antibody targeting VEGF-A and ANG2 receptors. It stabilizes vessels better than standard anti-VEGFs. The trials are underway for its efficacy in BRVO and CRVO. These are some of the trials which are available. The results showed comparable visual gains but better fluid control with faricimab, reducing injection burdens. Balaton trial is a multicentral trial, double masked, comparing faricimab with aflibercept for BRVO. The faricimab achieves similar visual gains as compared to aflibercept, with more patient extending beyond 12 weeks dosing. And it may provide faricimab provides better vascular stability and safety profile is comparable to aflibercept. This Comino trial was for CRVO and the results were similar as in the Balaton trial. Then we have new drug in town, aflibercept HD. The CAUSAR study examined an 8 mg aflibercept dose in RVO. It demonstrated significant visual gains at 36 weeks with longer duration, longer treatment duration. The safety profile was well tolerated, and it had comparable efficacy as compared to 2 mg aflibercept. Then we come to biosimilars. There are multiple trials with biosimilar. With the most important one was Razumab, the Caesar study. It showed a significant improvement in CDVA, improvement observed as early as first month, and it was comparable with the original ranibizumab injection. Then this is another fun from Reliance. This is Ranizumab Razor study. It was comparable to ranibizumab, the original molecule. Then these are some of the trials which are under trial for aflibercept. There is some trial with Samsung. There is some trial with Bioic, and we can see much more number of biosimilars for aflibercept after some times. Over the years, clinical trials have refined our understanding of RVOs from laser therapy to anti-VEGF agents and emerging therapy like faricimab. Our approach continues to evolve. The future research will further improve patient outcome, especially with gene therapies around the corner and with longer lasting treatment and personalized medicine. Thank you.
I would now request, thank you Dr. Rahul, I would now request Dr. Aditya Sharma to present management strategies, anti-VEGFs versus intravitreal steroids.
Thank you very much, Dr. Neha, and good morning to all. I'll be discussing about the management strategy of retinal vein occlusions, mainly anti-VEGF and intravitreal steroids. As we have learned by now that RVO is a vascular disorder leading to retinal edema and ischemia due to venous blockage. And the main culprit here is VEGF molecule, which is a key driver increasing vascular permeability and neovascularization. Also, the ongoing inflammation exacerbates the damage, leading to increased macular edema. The vision loss experienced by the patient is primarily due to macular edema, thereby requiring targeted therapy. Anti-VEGF therapy, which is considered the first-line treatment these days, acts by inhibiting VEGF molecule, thereby reducing vascular leakage and neovascularization. The common molecules we use are ranibizumab, aflibercept, bevacizumab, which is used widely but off-label use, and the new drug approved is faricimab. The clinical trials of these drugs have been listed here. What we follow is the initial loading phase, in which we give monthly injection for 3 months, followed by maintenance phase. In the maintenance phase, we have two options. First is PRN, that is pro rata or as and when required, and the other is treat and extend approach. Of course, there are some long-term considerations, like some patients may require indefinite injections, and switching agents may be necessary in case of non-responders, like less than 10% reduction in central retinal thickness after 3 injections. These are quite effective in improving the visual acuity of the patient, mean improvement of approximately 15 letters in cases of CRVO and BRVO, and leading to significant reduction in the central retinal thickness on OCT imaging. Of course, all good things come with certain limitations. Here the limitations are frequent injection that adds on to the treatment burden of the patients. Also, some patients may exhibit variable response, like some may show partial response or some may show inadequate response. Also, the adverse effects like conjunctival hemorrhage, mild discomfort can be there, and rarely endophthalmitis can be seen. Coming to intravitreal steroids, these are alternative and adjunctive therapy that act by inhibiting inflammatory molecules, reducing vascular permeability and macular edema. Common agents we use are dexamethasone implant Ozurdex and triamcinolone. Dexamethasone is a slow release implant effective for up to 6 months, and triamcinolone is used off-label in cases of RVOs. Clinical trials that support this steroid use are SCORE and Geneva trials, as discussed by my colleague Dr. Rahul. Ozurdex is given every 4 to 6 monthly based on the patient response. Triamcinolone is given in the similar way in 2 to 4 months. And combination therapy can be considered in refractive cases and in cases of central retinal thickness more than 500 microns and with neurosensory detachment. Steroids are also effective in reducing macular edema and improving visual outcomes, and the results are comparable with that of anti-VEGFs. But the duration of effect is usually longer than the anti-VEGF injections. And some other routes through which steroids can be given in RVOs are posterior subtenal injection or PST and suprachoroidal triamcinolone acetonide implants. Of course, as we can expect, intravitreal steroids do have some side effects like cataract formation and elevated intraocular pressure that can lead to glaucoma. The mechanism of action, duration, side effect, and the patient profile helps the clinician to decide the modality to go with. So these are the parameters we need to look for when choosing the modality of treatment. So when do we choose anti-VEGF and steroids? These are anti-VEGFs are the first-line drugs these days and are recommended for most RVO patients. These are ideal for young patients and those without contraindications to the drug. And on the other hand, we have steroids that are used as adjunctive drug and useful in non-responder cases to anti-VEGF and considered for patients who need longer lasting effects and fewer injections. This is a case of a 55-year-old male with CRVO. We gave monthly doses of razumab injections, 3 doses, and the patient responded really well to the drug. The second case of a 54-year-old female with BRVO, we had to give anti-VEGF for 3 months, and then we switched the patient to dexamethasone implant, Ozurdex, and you can see how well the patient responded. Coming to combination therapy, these target both the VEGF-driven and the inflammatory pathways. And these can be given like initially anti-VEGF and then steroid, or both the drugs can be given simultaneously. Coming to future developments in RVO treatment, we have sustained release implants, Verisome, which is a sustained release drug delivery system, and with triamcinolone have been tried for RVO patients. Biosimilars like razumab, Yesafili, and Opoviz have been recently approved. And these are the various therapies that are in the pipeline. Tarcocimab and vorolanib, bevacizumab is being considered on label now. Coming to patient education and compliance, which holds really an important place as most of the cases have metabolic disorders. So the importance of regular follow-ups have to be emphasized as clinicians to the patients. Also the side effects that can occur have to be managed appropriately, and lifestyle modification, which is the most important thing. So the key takeaways are anti-VEGF is the first-line treatment for RVO patients. Steroids via various routes provide an alternative in refractive and chronic cases. Combination therapy can be effective in select cases, and the new emerging treatments improve long-term management. Thank you. Now I would like to invite Dr. Bharti to discuss laser management in RVO patients.
Thank you, Dr. Aditya. Good morning, everybody. I will be talking about the role of retinal photocoagulation in retinal vein occlusion. So this is the overview. We'll be talking about the types, indications, benefits, limitations, and the current trends in the RVO management. So we know how photocoagulation works. It causes the scarring of the retina, leading to decrease anoxic areas and decrease VEGF. So there are different types of photocoagulation. It can be scatter or pan-retinal type, sectoral or grid laser in the periphery, or focal laser photocoagulation. It treats widespread retinal ischemia by creating multiple burns throughout the mid-periphery and peripheral retinas. Now, as has been discussed earlier, BVOS, CVOS, BRVO, and CRVO studies have already established the role of laser treatment in RVOs. And as my colleague Dr. Aditya has already discussed, the first line of treatment is now shifted to anti-VEGF therapy. So laser therapy now acts as an adjuvant, and it decreases the frequency and number of anti-VEGF injections. It also helps in prevention of retinal ischemia and neovascularization, and eventually neovascular glaucoma in ischemic cases. Patients in whom prolonged injection course and frequent office visits for injections are not possible, laser can be considered. Patients with medical comorbidities where anti-VEGFs and steroids implants are contraindicated also seek benefit from laser therapy. Patients that have minimal response to anti-VEGF injections are also considered for the laser photocoagulation. Now, role of photocoagulation in ischemic CRVO. As we know that ischemic CRVO can lead to neovascular glaucoma, also known as 90-day glaucoma, as it commonly used to present around 3 months, which has now shifted to 180 days or 6 months after the initial ischemic event. So, the prevention of neovascularization is caused by peripheral retinal scarring, which would eventually decrease hypoxia and angiogenic factor production. Long-term visual outcomes, as we know that PRP would stabilize the visual function in many patients, although it may not restore vision in severe ischemic damages. Integrating it with anti-VEGF therapy can optimize patient outcomes. Now, is the neovascular glaucoma is a complication of all type of CRVO? No. So, while deciding for the photocoagulation, we must know what is the role of PRP in prevention of NVG. The risk of CRVO developing into neovascular glaucoma is only 7 to 8%. And PRP has deleterious visual side effects like loss of visual field. Now, role of focal or grid laser in BRVO. It prevents neovascularization in patients with significant retinal ischemia. It also manages macular edema. Targeted focal laser treatment can effectively address macular edema. Long-term visual outcomes in photocoagulation helps in sustained vision acuity improvement. Long-term studies have revealed that retinal photocoagulation significantly enhances visual acuity in patients with retinal vein occlusion, with approximately 70% maintaining or improving vision over extended periods. Like in the diagram also you can see with the laser, the macular edema also decreased over time. Now there are a few limitations and considerations with the PRP or the laser photocoagulation in RVOs. It does not address the underlying blockage. It does not remove the initial blockage, so requiring concurrent management of risk factor is required. It can cause disturbance in the potential visual acuity like visual field loss and in few cases vitreous hemorrhage as well. Patient selection criteria is by identifying appropriate candidate for photocoagulation that requires thorough assessment of individual risk factors, health status and specific visual needs. So the current trends in RVO management is that with the effective use of anti-VEGF agents in conjunction with laser treatment, now we have a more comprehensive approach to managing RVOs. With the advancement in anti-VEGF therapy, we have significantly improved management outcomes in RVO, representing a critical advancement in therapeutic options. Also, as has been discussed earlier, follow-up duration for the neovascularization has now increased to 6 months after the advancement of anti-VEGF therapies. The take-home message from the presentation would be, RVO is a common cause of vision loss. In fact, it is the second most common retinal vascular disorder after diabetic retinopathy. Systemic diseases play a major role. Hypertension, diabetes, hyperlipidemia are the most significant risk factors. Thrombosis is the key pathophysiology. Venous stasis, endothelial damage, and hypercoagulability that makes virtuous triad contribute to the occlusion. In the central versus branch RVOs, CRVO has worse prognosis than BRVOs. In ischemic and non-ischemic, ischemic has high risk of complications like neovascular glaucoma and that requires close monitoring. Macular edema is a leading cause of vision loss and it is essential for, and OCT is essential for diagnosis and treatment planning. Anti-VEGFs are the first line therapy. Steroids and laser therapy acts as adjuvant. Steroid can be used in resistant and inflammatory cases and laser helps in neovascularization, although it may cause field loss. Systemic evaluation is crucial as it may be a marker of underlying cardiovascular disease. Patients should be screened for systemic risk factor. Early diagnosis and timely management improves outcomes. Prompt intervention can preserve vision and prevent complications like neovascular glaucoma and permanent vision loss. Thank you.
Thank you, Dr. Bharti. Today we have on our panel, as I have already introduced, Dr. Sarita Berry ma'am. She's our guru and the chief instructor Ma'am is Director Lady Harding Medical College and has been heading the retina services there for over 25 years now. Also on the panel, we have a dynamic vitreoretina surgeon, Dr. Pavan Puneet Malhotra, having done his ophthalmology from PGI Chandigarh. Sir then went on to do a vitreoretina fellowship from Sadhguru Netra Chikitsalaya, Chitrakoot, and now sir is the senior vitreoretina consultant at Sohana Hospital. Welcome, sir. Before sir presents his keynote address, I would request Sarita Berry ma'am and sir to tell the audience and for our benefit as well that how do they approach a patient of RVO in their retina services. Ma'am.
Thank you, Dr. Neha. So, just winding up our talk on RVOs. So, first of all, I would like to say that though the world is going into the very costly therapies like all the anti-VEGFs you hear about, Faricimab, Aflibercept, so a poor nation, a developing country, we also have something for everybody. So, we have biosimilars, we have triamcinolone. If we don't have Ozurdex, but we have triamcinolone, which has given very good results as well. And lasers are always there. Lasers are not only for people who cannot afford Aflibercept anti-VEGFs, but also it is a must for ischemia which develops a little later. Nowadays, a neovascularization can still occur. So these, as I had already said in my talk, these patients needs long follow-up to see that this may still develop NVG, NVI. So as Dr. Neha said, how we go on when a patient comes to us with this history as these cases. So if the patient is above 65 years of age, then hypertension, diabetes, hyperlipidemia, KFT, CBC, these are the routine 5 tests which we ask for: vision, intraocular pressure, and pupils. The RAPD has to be noted. So these, after this is done, then we dilate the patient. So before dilatation, vision, IOP, and pupil reactions is a must. Then we dilate our patients and take the patient right to the OCT, which is just next door. So once the OCT shows how much of macular edema is there, and that is the beginning of our management, which starts, we start with anti-VEGF, as this is the first line of treatment. Before anti-VEGF, we also ask a patient to get a ECG done and a history of cerebral vascular attacks. If there is any, and we have to tell the patient that there could be some any myocardial event which can happen, and if there's already an event, then we straight away go for steroids. If the patient can afford Ozurdex, if we cannot afford, then we take triamcinolone acetinoid, which is a very cheap medication, but I must say it's quite effective. If we cannot, if it's a phakic eye, then we give subtenon, and if it's a pseudophakic eye, then we give intravitreal, and we monitor the IOP as the patient follows up every week after the injection, and after they usually respond to any one of the treatments, the anti-VEGF, we see the response every month, and monthly injections are given by anti-VEGFs. In our hospital, we are lucky that we are having government given anti-VEGFs, so poor patients get biosimilar every 3 months, every 1 month for 3 months. If the responder, we continue PRN, and if it's a non-responder, we either add triamcinolone, or if the patient can afford, another anti-VEGF. This for 6 months follow-up is a must for all patients. Patients in the beginning have to be told that they have to come every month for 6 months, because our patients come from very far off India. So the one injection, they feel, ho gaya injection, and now no more to follow up. But they have to follow up for the 6 months. Otherwise, whatever injections we have given go waste. So this is how we manage, and at 6 months we see how much ischemia is there. And if the ischemia is more, we do a preemptive laser, because our patients do not come up. And if the FFA shows that there is more than 50%, as the ultra-wide nowadays, the more than 50% of ischemia, we will like to preemptively laser the periphery, leaving the posterior pole, and then we are safe for the patient. So that is how we go on. Thank you for giving me this opportunity to speak.
Sir, what about you, sir? Anything you would like to add?
First of all, I will congratulate Dr. Sarita for such a comprehensive covering all the aspects of the lasers. The first, the common problem which we face when the patient with RVO comes to us, that after one injection, the patient, the edema stabilizes. Then convincing the patient that you get 2 more shots in the eye, we try, the part of the counseling is the most important part, which we try to convince the patient. When the patient comes to us and we try to say that we have one good news and one bad news for you. One good news is that you have been saved of a major CV attack or a major, cardiac event. But at the same time, you are more prone to have such attacks in the future. So one test which has been, two tests which what is most commonly we come across is serum homocysteine as the ma'am stressed for, and the second, the carotid Doppler. Many times we see for those plaques, and we refer those to the cardiovascular, our friends, and they take care of that part, whether they want to put it on, blood thinners or not. The second aspect is that if we see the, as all the studies says, 60% of the patient will have the recurrence. This is the bad news which we tell them, that we don't know when you're going to have a recurrence within 3 months or within 3 years. And the post-COVID vaccination, to a certain extent, we have seen this coming more, and the dehydration part which you said, we see many of these players at times, young players coming after, gymming, and at time having these occlusive vessels. The concern is that convincing the patient for 3 shots, then just to explain, then it will reduce the recurrence. The second part which we face is when the patient comes of a glaucoma comes to us, and it has a recurrent and at times is a chronic edema, so whether we can give a Ozurdex or not. So there was a nice study from SN which they have given, and the surgical requirement were hardly in 1 to 2% of the cases. Even in the cases of the glaucoma, you can try Ozurdex, where if the IOP increases, it can be controlled with anti-glaucoma medication, and only 1 to 2% of the patient will need your surgical approach. The concerns are whether you will laser a patient or not. Definitely, if it's in the periphery, and you should laser that. But the cases of the macular BRVOs, when they are recurrent, we have been seeing that even with the help of the Pagenex and all this, they are responding much better and giving a much longer time for for the recurrences in such cases, and trying grid laser in such patient, in the young patients initially, it will lead to as to the presence of scotoma. And one of the most important point, Dr. Sarita Barry ma'am stressed that nowadays we come across all these new vascularization at 6 months, not like 3 months or 90 days they used to say earlier. And this is one of the few points I would like to stress upon. Thank you.
Thank you so much. So, in case if after first injection, if the edema is gone, then we do not want our patients to be convinced for the second injection, because it could be a natural history and the edema has gone. So, we will like to wait. So, sometimes our PRN starts from the first injection only. So, we never give an injection if the edema doesn't come back again.
I just saw some slides, they're giving 3 injections. Practically, we give 1 injection and start PRN from the right then only. I'm showing them some of the edema has left. We try to convince them for the second injection. But the actual approach is give the first injection and then try to follow the patient on the PRN. But do not extend their follow-ups for so long that you can come after 6 months. Unless you have done a FFA at 6 months, we cannot assure them the time of their follow-up interval. We should not extend to such. Thank you.
We'll be very delighted to answer. Keynote address by Dr. Pavan.
So, good morning once again, and thank you so much, Asia Pacific and AIOS for the invite. And we have been in the Bhutan with Dr. Neha, where the similar session of talk was given to me. So we know that the retinal bleeds can be subhaloid, subilam, intraretinal, subretinal, as caught in a single frame in one of my patients. Today we'll be talking about the subretinal bleeds. And that too can have a different presentations from minimal to massive, at times involving whole of the macula. But what's the need of removing this blood? First is iron is toxic to the photoreceptor. Fibrin can lead to shearing stress on the retina. These clots can get vascularized over time and can turn to CNVM. The causes being the AMD, PCV, RAM are the most common causes, and systemic association we know. We call it significant when it is occupying more than 4 diopter of the area. The prognostic-wise, the size less than 4 diopter is good, duration up to 2 weeks is better, thickness up to 300 microns, and the etiology, obviously when the choroid is not involved, so like trauma, RAM and Valsalva, the results, the prognosis is better. Like in this case, we had just had a trauma in one of the cases where, you know, just with the pneumatic displacement, the patient got a vision of 6/9. Why? Because the choroidal rupture was just abutting, it was juxtafoveal in the region, and the fovea was split. The similar patient, when it comes with the CNVM with the bleed, 1/8 patient scarring in the other eye, right eye CNVM, we advised the injection with the pneumatic displacement. Within a week, the vision improved, the blood disc got displaced, and within 6 weeks, it improved to 6/12. Advised 3 monthly injection, but as the scenario is when the vision is gained, what's the point? So patient lost to follow-up. Came again after 3 months with a rebleed of vision of 3/60. One-eyed again opted for the same because he had improved earlier with the pneumatic displacement along the anti-VEGF injection. And with displacement now was, you know, serious for the injections and got the vision with a 3 monthly of 6/36. In some of the cases where you have a, you know, bleed, the fresh bleed in the, over the CNVM, the other eye is good, you can try for the surgical intervention. As in this case, so the surgical procedure is still do the vitrectomy. Thereafter, you know, do the base dissection because you're putting the gas. Then inspect the area of the bleed, the extent of the bleed. At times, you have to plate this so that you know, raise the pressure inside. Then, with the help of the 38G Medon cannula subretinal cocktail of air, BSS. I prefer BSS than TPA. I don't know what is in TPA. So it's followed by the fluid exchange and partial fluid exchange, I will say, and the patient kept for the sitting position for the 5 days. At times, you can catch this, you know, subretinal air and this in the, you know, C3F in a single frame. Very rarely, you should opt for, you know, these RP choroid grafts, I will say, autologous. In the cases where the anti-VEGF is totally contraindicated. In the cases where the, you know, have a 80 years of lady who can come for the injection, someone has told this lady that you will need an injection, almost 18 to 20 injections. She said, I cannot afford. Then Ayushman came to our savior, and we did the surgery in such cases at times. So it's the induction of PVD followed by the base dissection, and thereafter you induce a localized detachment in the area of, you know, where is the abnormal retina as well as of the area of the normal retina. Do the fluid exchange, it will push all this fluid behind, then do 180-degree RR. This extensive surgery should be tried very rarely, I would stress again. Then you fold the retina on itself. Thereafter, the underlying CNVM complexes as well as the blood and the anterior attachment, you see that has two been separated. Then you eat all this complex and the blood and all this, you try to, and then you cauterize the feeder vessels there. Then from the area of the normal RP choroid, do the cautery for the size of graft. I try to use the curved scissor with which I separate and, you know, give the nick and use it as a forceps only. Then hold it at the edge, do not at the center, because we are trying to do the RP choroid grafting. Then PFCL is transformed from the underneath to the over the retina, taking care of the graft not to move. Thereafter, you laser and then the routine steps of the PFCL oil exchange, and you can see the result in this case. Luckily, patient also gained the vision. The graft nicely in place and counter finger up to ½ meter. Trauma post-plaque perforation is another cause for subretinal bleeds. Patient came to us, full chamber hypemia. We did the wash, did the lensectomy, and what we saw that there was some large bleeds there, and you see 5, it was perforated at 5 sites and big crescentic macular hole like tear in the center. And you do the vitrectomy. Thereafter, the options you sought for, then you try to plug this with the ILM plugs as much as you get from wherever. Thereafter, wherever you get the big flap, you try to cover it over the flap, and then the peripheral holes are laser. Thereafter, do the base dissection, because if you do an initial PVD, try to do the initial PVD in the periphery, you can induce the detachment. And it's over monthly follow-ups and the patient the last. And recently, we did the SFL in the patient gained the vision of 6/36 now. This case is very close to my heart, because manager of our age coming, one-eyed patient turned blind and came to reaches your clinic. It was HDFC bank manager from Delhi came there, you know, for editing whatever they do in the end and in the September, and the eye was like this, big tear 180-degree in the only seeing eye. You're trying to under the muscles, you're trying to put the sutures, you know, and almost 180-degree, and you don't see anything inside. There's a detachment and there is a blood. You're trying to induce the PVD. You cannot induce because there's a subretinal blood with a detachment. Then you make a pocket in the, you know, hole in this highlight and put a PFCL, try to push it behind. Then you try to take this blood. I tried it with a soft tip first. It wasn't coming. It was big clotted blood. Then I'd use the endolite in my left hand to put some of the counter traction, but still it was not coming. Then I'd use this cutter, and we call it the spaghetti technique, on which we try to roll these big sheets of the clotted blood over itself. The rest of the blood is taken of the loose blood, and it is followed by the routine procedure. And this was we left the PF cell because whatever the PF cell I was putting, it was coming out of the big tear. So there was no option than putting a PF cell for some time and making the patient lie straight, because so that the retina settles to some extent. Then using this suture, Prolene suture, which will try to hold the oil behind, and in the second setting, and nothing can be more satisfying to see the patient coming to your clinic, himself in your center will try bypass the Sardarji himself. And this is one of the things which we try to strive for. And now, last month, 2 weeks before, he has come with the sweets. Uski beti hui hai, and nothing can be more happiness, give you more happiness than this. So this is diabetic with subretinal bleed. The lady from Saharanpur came to us. Otherwise, NVG, the right eye, you see, we do the vitrectomy, then try to do the vitrectomy, then you see, oh my God, still a lot to do, a lot of membranes, a lot of blood lying there. You try to do put the oral cords, try to separate it. Then you make a sort of opening there, try to stabilize with the PFCL, blood piche na chala jaye, thoda bahut fovea bacha rahe. Then you make an opening and try to take all these clots and all this clotted blood from there, loosen blood, you try to do. Diabetics is the biggest challenge nowadays, and thereafter, the patient was blind for more than a year, and 624 she gained. At times you have to take these big hard exudates, subfoveal clots by making retinotomy, no option you have in blind patients. And you can see that retina is being settled when they do the scan, raster scan from up to down, and the patient gained the vision of quantification 1 meter. Unfortunately, after 18 months, she turned up blind again, because this is, I could help out for this 18 months, but we have to accept the truth at times. In the end of cases, at times you have a serosanguinous bleed. To drain that, just place this cannula halfway, and this come itself, and not push it totally in, because the retina can get incarcerated and put a pressure. So to conclude, I would like to say that minimal bleeds you can observe or give anti-VEGF depending on the cause. Slightly more, go for pneumatic displacement. If your patients have a good other eye, then go for the surgical procedures. And subretinal BSS is better than the TPA, because TPA doesn't have seen it doesn't migrate to the studies by the Kamai and the Levi's have told it doesn't migrate to the initial people used to give intravitreal, you have noted, but now they're trying that, and then they tried subretinal, because it doesn't penetrate the retina per se, and need to have some break, and very, very rarely, I say, use opt for such extensive surgeries. Thank you everyone for the patient hearing, and especially to my teachers for all the learning I have.
Thank you, Dr. Pawan. It has been a very nice video session and really heroic surgeries, and giving some vision to the patients where everything is lost.
And someone has to take a call, because doing surgery in such cases, even if you gain 4 of the patient of the 10 you operate, it gains 6 will curse you, but we have to be happy with these 4 who comes to your clinic walking. Thank you so much.
We can understand how difficult it is in the OT when you're sitting for long hours and seeing what would the result. You never think of that. You just do your best. Thank you.
Thank you so much.
Thank you, Dr. Pawan. Any questions from the audience?